Well, hello everyone. Good morning. Thanks for joining us today. My name is Adam Shoemaker, Director of Healthcare Consulting Services at Dean Dorton. And on my watch, it is 11 a.m. Eastern. So we will get started here. There will be others that probably join in the next several minutes, but we'll go ahead and kick this off. Thanks for joining us today. We're going to have a conversation around the dynamics of providing health care in underserved areas, whether that's an FQHC in the urban setting or a rural health clinic. Um, in the mountains of Eastern in Kentucky, they have their unique challenges and certainly opportunities. So we're going to discuss that today. We're joined by three experts in their field: Dr. Jody Prather, MD, President, CEO of Health Source of Ohio; Dr. Anthony Yance, owner and operator of Mountain After Hours Clinic; and my friend and colleague, Mr. Jeff Presser, Associate Director here at Dean Dorton. So with that, gentlemen, Dr. Prather, why don't you start us off and do just an introduction of yourself and your organization, if you don't mind?
Yeah, Adam, appreciate that, and thanks for asking me to be with you guys today. So, as he said, I'm Dr. Jody Prather. I'm a family physician by training, a lifelong Kentuckian. For background for folks, I practiced in Elizabethtown. Never thought I'd be a suit necessarily, but I was asked to be the CMO at Hardin Memorial years ago, 15 years ago or so, before it became Baptist Hardin later. Then became CMO of the Baptist Health System, Chief Strategy Officer at the Baptist Health System. And then last spring, I decided to take a giant leap of faith, largely based on a desire to be involved in the mission of an organization of the largest community health center group in Ohio, and it's called Health Source of Ohio, based in suburban Cincinnati, but we cover 8 counties in Southwest Ohio. To give you some sense of scale, we're about 25 locations, 85 million-ish in revenue, 450 employees, and I'm glad to say growing providers, 90, approaching, climbing towards 100, which is certainly a goal in the short term. We have family medicine, pediatrics, OBGYN, behavioral health, and dentistry. And a little bit interesting, we're a little unique in that we cover some fairly urban areas in eastern Hamilton County, then some suburban areas in the kind of the ring around Cincinnati, but we get into true rural country as we go some of our 8 counties east. And I joke, just so folks know, I'm if there's a Kentucky heavy group here, when they told me, well, I had part of my service area was Appalachia, I said, oh yeah, sure, Appalachia. I know Appalachia, and I doubt that's Appalachia. But when you get into parts of Southwest Ohio, it surprisingly feels like parts of Eastern Kentucky that I spent a lot of time over the years. So good spread, and it's been great to be there, and I'm excited to share a little bit of what I learned here with you guys today. So thanks.
Absolutely. Thanks for joining us. Appreciate that. Dr. Yance, you want to do the same thing? A quick intro and background on your career.
Yeah, absolutely. Good morning, everyone. Appreciate the opportunity to join in with this. Appreciate the invitation. So my name's Anthony Yance. I'm a DO physician in southeastern Kentucky. Actually did a med-peds residency at the University of Kentucky prior to coming back home. We started a rural health clinic about 18 years ago. Been very blessed to grow and expand that. We're in 2 counties now here in Eastern Kentucky. Rural health clinics are a little different in that, of course, each entity is a unique entity. You don't have the ability to do umbrella clinics off of that. So a little bit of a different growth model and challenges there in comparison to the FQHCs. But we currently have 28 total providers covering internal medicine, pediatrics, family practice. We have rheumatology, dermatology, and psychiatry, along with some behavioral health that we do. My primary clinic is in Perry County. And we also participate in providing hospital services for 3 different hospitals. So we've kind of got a little bit of sticks and a lot of fires, as far as that goes, trying to expand our footprint. But yeah, really, really glad to be here today.
Awesome. Well, thanks for joining us. I appreciate that background. And then finally, Jeff Presser, colleague of mine at Dean Dorton. Jeff, you want to introduce yourself to the audience?
Sure. I'm glad to join and happy that you all are participating in our webinar. I've been in healthcare for about 35 years, mainly focused on the reimbursement side of healthcare, anywhere from Medicare cost reporting to net revenue to rebasing rural health clinic rates. So I've been both my work experience is both with insurance companies and consulting and with health systems where I worked with Dr. Prather for a number of years. So good to be here, and hope you guys learn a little bit about RHCs and FQHCs.
Awesome. Thanks, Jeff. And just one quick housekeeping comment. We are recording this. We'll distribute it at some point after the session. And there is a chat feature. If anyone has any questions, feel free to enter it in the chat box. If we can get to it, we will. If not, we will follow up with you after the fact. All right, let's kick it off. Dr. Prather, you alluded to spending most of your career within a health system environment. Talk to us a little bit, if you don't mind, just the similarities and differences between a multi-billion, multi-hospital system versus your current organization.
Yeah, well, Adam, there's some similarities. There's some real differences, of course. Health source, and I'm sensitive. I want to make this as valuable as possible for the audience. I mean, of course, we have a little more scale than some of the FQHCs out there, although there are many that are bigger than us. So we have more scale than some. But I can say, of course, out of the gate, scale is the huge difference, and that's good and bad. I joke, and Jeff can appreciate this, and many of y'all, if you're in health systems, can appreciate this. I say that I don't have to go to 3 committees and 2 lawyers to spend $20,000 anymore, which is a blessing. And so from the strategic standpoint, you certainly can act quicker, move quicker, as you're negotiate with physicians. It seems much more streamlined. The downside is we just don't have as many internal resources. That's just the nature of it. And so, some things we just do without, and some things we use a lot more external vendors than I'm used to. And IT kind of being its own issue, which, we may talk about later. I won't go down the IT rabbit hole quite yet, but, and the business model in some ways is similar and quite different. It's similar, from when I was chief strategy officer at Baptist, because patient lives and volume still is the straw that stirs the drink, so to speak. One big difference, of course, is the main income is we're having to make it on physician pro fees versus the hospital model of the old downstream, which I used to chase pretty heavily. And now for an FQHC and for primary care clinics, of course, and like Dr. Janssen, RHC, that's certainly not the focus. Most of you are probably aware that, we have some advantages on the FQHC side. I think Jeff's going to talk about this some, so I won't belabor. The PPS, prospective payment system, that we get from the governmental payers, which is more cost-based, and our 330 grant. So we do get some grant dollars, although at Health Source, it's only about 10 to 12% of our revenue, but we do get those. One similarity that I'll mention, and, whether it's here or elsewhere, is worth discussion is, we are a 340B grantee. So when it does come to downstream, that is of significance for us. And, frankly, I think if you're an FQHC and not trying to maximize that revenue, you probably should be. And then one other thing I'll throw out, thinking about this group in my mind, is, I think the value-based focus is a little different. We certainly had value-based shared savings initiatives in the big health system, but the discussions are a little different. Of course, it's a much higher percentage of revenue. And as we have those discussions, I don't have this push-pull of us decreasing our own utilization, which I think naturally occurs within health systems. So I'm very, I say excited, optimistic maybe is a better word about, how we're going to function in the value-based world. And we're spending some significant dollars trying to make sure that infrastructure is there, because I think that's one way we can do well. And then lastly, I guess, there's multiple, but lastly, continuum of care still matters. As a family doc, and Dr. Jans as a med peds can speak to this. Now, I think patient outcomes just benefit if you're really focused on the patient journey across the continuum. And in a healthcare system, you kind of put all those pieces together yourself. And as FQHC, I spend a fair amount of time working on those kind of partnerships, trying to, have that in place for the patient, both somewhat for our benefit, but frankly, largely for patient outcomes. So, whereas before we maybe had a lot of those pieces in place, now we're trying to, for lack of a better term, cobble them together. And so that's a little different as well. So anyway, I could go on, but that outlines the ones that I think about primarily that maybe help get the discussion started.
Great. That's an interesting perspective since you've been in both worlds. So I appreciate you sharing that. Dr. Jans, what about you in your practice? Where are you able to, work with the hospital? Where do you collaborate with the, health system or hospitals in your area?
Yeah, it's when you're in a private practice rural health clinic, your relationship with the hospital is very love-hate, right? And so, on one hand, they have all the advantages from every standpoint, from better reimbursement on procedures and diagnostic imaging and labs. So those are things that we generally, in a rural health clinic, stay away from. But there's also a synergistic effect. We provide a lot of the hospital services for 3 of the local hospitals. And Dr. Prather hit the nail on the head. Even though the value base is something that we're all trying to explore and figure out, at the end of the day, it's still a volume-based revenue model that we're looking at. And so, certainly those hospital encounters, count into a revenue source for us. Our relationship with the hospital has, I would say, overall been positive in our area. We're in a very rural area, and getting access to specialty care is one of those things that is a constant challenge for our patients. And so, one of the things we're constantly pushing the local hospital for is to bring in more specialists, and of course, they have dollars that has to make sense for them when they look at any specialty field that they bring in. And for us, years ago, we started for some of our low income populations, those with commercial insurance but are essentially underinsured, working on cash pay deals for labs so that we can reduce the cost of labs to the patients. And we often end up covering that cost at the end of the day, because a lot of those folks just can't afford to do that. Same way with diagnostic imaging. The reimbursement for hospital systems is significantly more than you can get reimbursed in the clinical setting. So those are things that we typically stray away from, and work with the hospital and support their imaging center. So it's overall, it's a relationship that whether we want it or not, both parties need. So the challenge for us in our area is to work together and not against each other in that. And certainly from a primary care perspective, one of our challenges is the pendulum seems to swing about every 10 to 15 years with hospital systems. So they go from wanting to own every primary care practice in the surrounding area to not wanting anything to do with primary care and just wanting to do specialty care. So and in our area, we're kind of in that where they're wanting to get back and own all the primary care parts. So it's always a changing dynamics on that. But again, I think to kind of highlight for us in a rural health clinic, working with the hospital system to increase volume and encounters when we see hospital patients, and supporting them from everything from diagnostic imaging to specialty referrals, which benefit our patients.
Sure. Jeff, Dr. Yance was talking about reimbursement, and the differences there. What about, from you're our reimbursement expert here at the firm and work with, clients all across the country. For some of the folks on the call, they may not be familiar with the nuance of reimbursement within an FQHC or a rural health clinic. So just educate us, if you don't mind, just how is it different? How is it similar? Kind of what's the mechanics of reimbursement here?
Sure. From a perspective of a private practice to an FQHC to an RHC, there's both similarities and differences between the three different healthcare types. The similarities being that all three provide healthcare services. They employ qualified healthcare professionals such as doctors, nurses, specialists, similar regulatory oversight. All are subject to regulations to ensure safety and effective patient care. And ultimately, the goal of the three provider types is to share a common objective of improving health of their patient populations. Some of the differences would be a primary care are focused on individual patient care, being reimbursed from a professional standpoint, and FQHCs, they serve a underserved area population and provide comprehensive care regardless of the ability to pay. And from an RHC standpoint, that they increase access to primary care in rural underserved areas. From a funding perspective, typically private practice relies on patient fees and insurance reimbursement, which typically are fee schedule payments. FQHCs receive federal funding and grants, are cost-based reimbursed from Medicare and Medicaid, and may offer some type of discounted services on a sliding scale. RHCs similarly receive all-inclusive rates for Medicare and Medicaid. And as far as governance, physician-owned practices are not required to have a board of directors. FQHCs are governed by a board of directors with patient majority at least 51%. And usually with RHCs, they're privately owned, and CMS does not require a board of directors. From a location perspective, private practices can be both rural or urban. Similarly, FQHCs can operate in both rural and urban areas, but they must be designated as medically underserved areas, and RHCs must be located in non-urbanized areas designated as health professional shortage areas. So
Yes.
that is some of the similarities and differences between private practices, RHCs, and FQHCs.
Thanks, Jeff. And I think the key word there is underserved, and that was obviously part of the call to action here in this conversation was underserved. And Dr. Prather, we've seen a lot, we've read a lot about the recent regulatory One Big Beautiful Bill, the passage of that legislation. Without getting, maybe overly political, how have you looked at that legislation and the potential impacts, if any, on kind of your organization and your underserved patient base?
Yeah. Oh, Adam, there are definitely impacts. We're about, some FQHCs are higher than this. We're around 50% Medicaid as far as our payer mix. And so, it's going to have implications. there are going to be less people. There are going to be people coming off Medicaid. I know the number I've seen that I trust the most in Ohio is about 400,000 less, more than likely. So between the work requirements and the 6-month redeterminations, there will be people come off Medicaid. Now, how many of those are the young, able Medicaid beneficiary we're talking about versus just people who maybe deserve it and are having trouble with the administrative burden? That's of course the big question, right? But nonetheless, what we're trying to do, so mitigation strategies, and we're trying to focus on some upfront engagement because for Medicaid beneficiaries at risk, because we do think the people that lose Medicaid, many of them probably are going to be eligible relative to work requirements and all those things, but just the administrative burden is going to be there. So we're fortunate at Health Source. We've got some resources around Medicaid onboarding and enrollment already. We're going to and we had a grant. So back to grant dollars, FQHCs, we've been more focused on grants here than I was in my health system world. At least my awareness of them is a heck of a lot more. We had a grant for Medicaid onboarding enrollment. That grant's gone, by the way, which maybe isn't surprising given some of the moves coming out of Washington. So we're looking at some of those folks and saying, how can we repurpose them to look at to reach out to some of our folks and that may be more at risk. We'll see how that works. I mean, we've got some time before work requirements come in, but we're trying to think of it in that regard. But the big impact for us, and you alluded to it, both of you guys did, at the end of the day, community health centers, we want to take all comers. We have to take all comers. I joke we're the EMTALA of primary care. At the end of the day, the buck stops here. And if people don't have any ability to pay based on percentage of poverty line, we have sliding scale to wear down at a certain percentage of poverty line. Essentially, they owe nothing. So we're still going to see those folks. That's our mission. That's what we want to do. But the impact of more uninsured will hit us. And so we're trying to minimize that by being proactive, talking to some of our Medicaid beneficiaries and trying to be of assistance to them. But at the same time, there's going to be more uninsured people. New patient acquisition is always an offsetting strategy, so as we know we're going to lose some, we're trying to figure out, okay, how do we grow? But, it's going to have impacts. Now, I will say this for the hospital colleagues that are on here, from a community health center standpoint, we didn't take in a way, maybe as big a hit as some of the hospitals did because again, just coming out of that world, I'm very sympathetic to the provider tax and directed payment implications that they just had hit, HRIP in Kentucky. And then in Ohio, they hadn't enacted it yet. They were planning on it, and that kind of fell off. So good news, we didn't have that. Of course, then there's this rural transformation fund out there, and everybody's trying to figure that out, right? But $50 billion over 5 years across the country, certainly, and I will say certainly, seems obvious it's not going to fill the gap. Interestingly, community health centers, and I think rural health centers, I mean, you all can speak to that, maybe are eligible for that as well. I know we are, but that having been said, there's going to be a lot of folks at the trough on that one. And, relative to what the requirements are, there's just more questions than answers. But, we're certainly following that right now and trying to make sure we're positioned to at least be at the table when those funds hopefully break loose. So anyway, maybe more than you wanted, but that's a few things on how we're thinking about the big, beautiful bill.
No, it's impactful. No, one about that fund, it's about decreases over the next 10 years. So there will be something there, but compared to the total Medicaid spending as of today, it's significantly less. Dr. Yance, what about you in your practice? Have you been able to assess, the impacts to Medicaid and funding over the next, 2 to 10 years to your practice?
Yeah, the one big beautiful bill is, like you said, in an effort to avoid the politics of it, it's almost impossible to discuss it without that, though. But there's both sides of the fences on that. On the one side, there's certainly healthcare spending and the dollars put in is just so outrageous. But when you're on the healthcare side, anytime you have something that decreases dollars and number of patients who are going to be insured, is going to affect your bottom line. And, for us in Eastern Kentucky, honestly, I started my practice in, rural health clinic and private practice prior to the Affordable Care Act. And so we budgeted 10% of our budget every month for patients who were self-pay, no pay. We've never turned anyone away. We give hundreds of thousands of dollars in free healthcare a year away during those times. And then when the Affordable Care Act come around, honestly, for us, that was bonus, and it allowed us to kind of expand operations and bring some other folks in, specialists and such. So, it's what we're anticipating. And again, I agree with Dr. Prather. I don't think anyone knows 100% certain yet, but we're anticipating kind of going back to the pre-Affordable Care Act days, to where we need to budget about 10% of our budget that we're not going to be getting paid for. Which, in a rural area is challenging, right? So if you look at the way that the pay scale has gone up across the board, whether you're talking about the pay that it's required to hire a clerk or a nurse aide, or whether it's going out and buying groceries, when you look at the inflation rate and you compare that to the revenue stream that you have in the healthcare, the revenue stream increase for healthcare has not kept up with the rest of the country as far as pricing. And so that I think, again, like Dr. Prather said, for us, we're looking at it strategically two ways. One is, for those that need it, how do we keep them qualified for their Medicaid benefits? And then number two, what are growth strategies that, that we can get some additional new patients in? And then for our standpoint, the Rural Transformation Act, $5 billion a year for 10 years or $50 billion over 10. We understand we're at the bottom of the totem pole. More than likely, those funds are going to be consumed almost exclusively by the hospital systems. And then, Dr. Prather is probably second in line in that list with the FQHCs. And then probably the nonprofit rural health clinics, maybe third. And then for the rest of us. So we're not anticipating any revenue at all related to that, or any financial support to that. So from our strategic standpoint, we're planning, strictly on, trying to budget a 10% cut. And similarly in Kentucky, I think that those are some similar numbers that we're seeing in the 350 to 400,000 range as far as less Medicaid recipients.
Jeff, what are you assessing and what are you analyzing as we think about less patients having access to Medicaid? What's the revenue implications from your team on kind of what you're helping clients navigate?
Well, from the standpoint of the One Big Beautiful Bill, I think Dr. Yance and Dr. Prather hit on the major implications, the negative implications being cuts to Medicaid, which potentially can impact the financial stability of FQHCs and RHCs. The provider tax limitations, which are used to draw down money from CMS, limitations on that, which decreases total funding for Medicaid, and then the coverage losses, which increase uncompensated care for FQHCs and RHCs. One thing that differentiates hospitals from FQHCs and RHCs is hospitals have the ability to get reimbursed for uncompensated care through the cost report. I think as part of as far as the positives of the One Big Beautiful Bill, as Dr. Prather highlighted, the Rural Health Transformation Program. I think, and for what I'm reading, that uh, ultimately it's up to the states to figure out how to use that money. But I think states are going to lean toward using that rural health transformation money to reimburse for uncompensated care as a result of the coverage losses, where you have charity and bad debt write-offs increasing. Some of this funding can be used to limit those losses from that, much like the hospital gets through the Medicare cost report. So that's what I'm seeing, and states will have, from what I'm reading, a lot of flexibility on how to use that for rural healthcare, and we will see what Kentucky, Ohio, Colorado, North Carolina, different states decide to use that for. But I would think that those funds that are being made available to rural providers will somehow cover their losses from bad debt write-offs to charity care from the coverage losses.
We do have a somewhat related question in the chat regarding pediatric eligibility to Medicaid. Have either of you thought through the pediatric nuance of the Medicaid impact to your practices?
Yeah, I mean, go ahead, Dr. Yance.
The way I read the bill, I don't think there's going to be any impact on pediatric coverage.
Well, I think initially that was the discussion, but I'm not, again, I don't, on a webinar, don't want to mislead people. I think there are some caveats in there that say that there's redetermination for all Medicaid potentially. So, trust but verify on that. My understanding, we heard from the national organization, is there is going to be some extra redetermination even for kids perhaps, but again, don't hold me on that, but I think that could be true. And so in which case, that's part of what we're trying to be, when we talk about being a little proactive and making sure folks have resources, and we're here to potentially help them with some of their paperwork. That's an audience we're trying to hit as well. But again, I think that's true, Jeff. I don't want to put you on the spot. You may or may not be aware.
Yeah, I'm not aware of any pediatric implications from the one big beautiful bill.
Yeah, I think the redetermination, again, I'm pretty sure the redetermination is the way it passed in final was all Medicaid enrollees.
Yeah, we went through that with the ending of the pandemic, the redeterminations, and which took over a year to do for the each state's Medicaid program. And I think you're right, Dr. Prather. I think we could see something like that again with the rules changing around eligibility, work requirements, things like that, another redetermination.
Yeah, and any guidance we see, we'll be sure to update the group and get that out to you. This is new to everyone, so as we work through it and get clarity on the legislation and guidance, we'll put that out there. Let's shift over to staffing if we can, because you're both working in two very different areas. Dr. Prather, you talked about really having three sort of distinct geographical footprints: Cincinnati, the suburbs, and Southwest rural Ohio. How do you staff that? How do you have a pay scale that sort of addresses that? What's the challenges of sort of staffing that type of organization?
Yeah. So yes, I'm looking for advice on how to have a pay scale that addresses that. But so this is an area that causes me more consternation than any, because I think from a strategy, I always say from a strategy standpoint, we can find the right locations. We know the patients are out there, even with the implication of some Medicaid enrollment reduction, but it's easy to build a building or open a lease space, but if you don't have caretakers and providers, that's everything. So inflation in that area has been dramatic for us anyway. I mean, we're constantly chasing and again, frankly, and understandably so, a lot of the health systems are setting the price of poker, so to speak. And, we're having to try to run that down because these folks have great skill sets and they can work anywhere they want. So it's interesting in our markets, it is a dichotomy in a way. We've got areas where we're competing with Cincinnati Children's and the Tri-Healths of the world and St. Elizabeth's and others. And then we have rural areas where maybe there's not as much competition, but of course, just fewer people. So we've really focused on our rural areas in some grow your own MA programs, which have been helpful. But make no mistake, we've since I've been here, I've had to raise salaries across the board in the last year, and in some areas, maybe a couple of times. Retention bonuses have become part of the strategy, obviously sign-on bonuses. Interestingly, and I don't know if any FQHCs are on, but the dental market for us has even been tougher than the medical market. Interestingly, dental assistants and hygienists, there's been even more inflationary pressure around that. So, there's really no way around it in most ways. Like I said, on the MA front, we can grow our own a little bit, but even with that, if you're not keeping up in wages, people will give you maybe $1 an hour benefit, but you get much beyond that. And you're going to see people jump for $2. And in fact, we have. So I think that's the difference is we're competing with other health systems in the Cincinnati area. As we get out east, there are hospitals there and health systems that have a draw, but it's much more just not enough folks interested in healthcare. And then you're trying to, very often entice people to be willing to take a 45-minute commute or something like that. So that's on the frontline staff. On the clinician side, frankly, from an APC standpoint, there are enough APCs relative to the supply and demand curve for us right now, at least. The challenge is experienced APCs. And as Dr. Yance probably can speak to as well, the APC training is somewhat uneven. And there are some APCs who come out of programs who are so strong, could out-practice me in a minute. And there are some who come out of programs with much less experience. So one thing that we have done, and again, it's added to the cost, is we've created like a 6-month fellowship, basically for untrained APCs, where we're paying them during a learning period. And so, that adds the bottom line, but we're willing to do it because it creates better outcomes and they're more comfortable, and hopefully there's an ROI generally, but certainly from an outcome standpoint. But on the physician side, then final thing, that's our biggest pain point. That some of the guarantees that are coming out of the health systems are significant. You got kids coming out who say, well, seeing $275,000 guarantees, and whether that's sustainable or not, I'll let somebody else comment. But certainly it's maybe sustainable if you're supporting it with dollars from high dollar services like neurosurgery and cancer and all those things. It's much less sustainable, even with PPS rates just on pro fees. So, it continues to be a challenge, and especially, not to act like the get off my lawn old man, but a lot of new residents coming out, lifestyle is very important. No judgment, but they didn't come out thinking they're going to see 30 a day and work 5 days a week either. And so, there's this push pull. And then finally in the rural areas, and I'll let Dr. Yance talk about this because this is right. It's so hard if somebody doesn't have a tie to the area, getting somebody to want to live in a rural area is just very, very difficult when they can look and say, okay, well, even in your company, I can live in Cincinnati and work in the suburbs, or I can go live in Hillsboro, Ohio, which is, much, much, much more rural. It's a tough proposition. And, then that changes the price of poker as well, so to speak. So inflation is across the board. And that's why, it's just, everybody knows this, trying to find more avenues for revenue to support that continues to be the challenge. So.
Dr. Yance, that's a great transition. You are in a rural area with a growing practice. How do you staff it? How do you keep folks, how do you hire them and keep them?
Yeah, honestly, I could just kind of be quiet and say, see Dr. Prather's answer. I agree, completely with what he said. And I also agree. I think that is for us, I think that's the way we break it down as well. So when you look at non-provider personnel, I've always told my staff from day one, as I remember well, the first meeting I had when we were getting ready to open up, uh, the most important people in our organization as far as patient retention and satisfaction are our front desk crew, or clerks and receptionists, right? So not only do we need them to smile and deal with at times belligerent people, but we also need them to collect accurate insurance information. And, some of this stuff we look at and we're like, how in the world can anyone make a mistake doing this? But, we also have to understand, there's different levels of understanding and skill sets whenever we're dealing with different personnel. And, I'm sure Dr. Prather and guys, even you all within your organization, you do the same thing. When you have young talent that comes in, what do? You promote them, right? And so, you have someone at the front desk who's just absolutely spectacular. Well, you end up moving them into administration or management position. For us, the cost of labor has really skyrocketed, and it's a challenge. And we do get the PPS rate, but we don't really have any other revenue source. So we are really forced to kind of eat what you kill, so to speak. And so any dollars that we spend, we have to generate through patient care. And it's in a rural area. You have a smaller population, so it's a smaller piece of the pie sometimes that you get. And Dr. Prather, I would also in our area echo the same thing from the mid-level provider standpoint. We do have quite a bit of those positions filled. And so it is a little easier to hire those positions. And we also have done a similar strategy in that we have taken on less experienced front desk people, nurses, nurse aides, and kind of train them in house, put that time and effort into training them in house. And I got to be honest, those folks that I've done that with over the years are not only my better providers and better workers, but also my most loyal folks also. And then I think for rural health clinics, one of the things, and we have done this for periods of time, but the reporting and paperwork associated has been a challenge for us. But given getting the National Health Service Corporation certification to where you can get student loan forgiveness for those individuals for coming to a rural area is an incredibly attractive program that you can get in in rural areas that's beneficial. And then from the provider standpoint, I smiled when Dr. Prather said that. But yeah, I mean, most of my physicians that I interview, they want to work week on, week off, or 5 days on, 4 days off. They want a starting salary of around 350 with full benefits. And even though they're working a week on, week off, they still want 6 weeks paid vacation. And when you're trying to, I just sit down and I show them the math. I'm like, look, if 100% of your patients were Medicaid, we have a PPS rate. This is how many patients you would have to see to generate that. And you can just see their jaws drop. They're like, there's no way I can see that many. And unfortunately, I have to just look at them and say, well, you're probably going to be better off served in a larger health corporation. And with very few exceptions, the talent that we're able to recruit to the area has local ties to the area. Again, I agree with Dr. Prather there. So, but yeah, for us, certainly the cost of labor is a challenge, and then just finding enough personnel to do it. There was a time, and it's been a rapid transition over the last 15 years. But when we first started, we had people beating the door down, calling every day, looking for a job. And now we'll post a position and it may be 2 weeks before we even have any interest in it. So certainly some challenges there. But the benefit of rural areas is the folks who are from there often have a passion and want to stay in the area.
Just a quick follow-up to that point around what you can recruit and what you can hire locally. Quickly, have either of you had to look at just completely outsourcing a function because you can't staff it, or look at hiring someone remotely wherever they may be for certain tasks? Have you had to explore that or do that yet?
I'll say there may be one, Adam, but I hadn't thought of it yet. I mean, what we do is more folks just have stepped up and done it. Now on IT, and we're going, I know we may get into it some. I mean, we outsource a lot of that because you really can't afford that talent at scale as much. So on the IT side, I would say certainly yes, but it's some of that maybe we're not even counting on trying to hire. Internally, it's just a matter of, so many of these positions that are hard to fill require boots on the ground. And so you just have to, everybody does what they have to do until you get that spot filled. Because a lot of the pain points are of besides IT for us are, those frontline clinical folks who it's really hard to do it any other way but somebody on site. Dr. Yance, I don't know what you would say.
Yeah, identical, same response. That's for for us daily operations. We have not had to outsource anything so far.
Let's shift over to technology. Stay with you, Dr. Yance. How have you been able to successfully sort of integrate technology improvements? How do you use it? What's the challenges there, the cost constraints?
So yeah, technology also is bittersweet in healthcare, right? So if electronic medical records were not mandatory, we probably would be able to get them for about 1/10 of the price that we're paying for. But they are mandatory, and they know that, and that's the way it is. But I think AI is really exciting, and some of these programs that they're building within the electronic medical records with AI is very exciting for us. So we recently, about a year ago, about 6 months ago, started a pilot with AI looking at decreasing dictation and cost associated with that. And it has been a profound drop, and the accuracy has been great. And my provider satisfaction has gone up so much since we implemented that. They're and I don't know how many of you all watching have demoed or used the AI programs. We're on a eClinicals. They have one. There's one DAX that's out there now, and it is just fascinating that this software has the ability to sit and listen to a casual conversation and pick out the pertinent medical factors, and then also putting in assessments, putting in plans, loading up the medicines, having them ready to be sent to the pharmacy. So for me, I think on the IT side, the most exciting part is incorporating AI. I think there's going to be cost savings and better efficiency that's going to come out of that. Of course, there's always the room for error, and so we have to be cautious when using it as well. But that's been an exciting feature. From a cost perspective, I mean, just the cost of electronic medical records are just absolutely out of control. And I mean, there's nothing that's ever going to happen with that, because no one really cares if you overcharge a physician or a practice too much. They just feel that's what you deserve. But it would be great at some point for someone to come along and say, hey, for these software manufacturers, your return on investment is just too astronomical. There has to be some middle ground there. And then from a hardware support, that has been our biggest challenge. We've had some times over the years to where we've had hardware failure, lack of backup that has been a tremendous challenge to us. And finding competent individuals to do that is certainly something I think Dr. Prather had alluded to. Is certainly something we have outsourced over the years, and even when outsourcing, it still has been subpar. So I think there's certainly some positives with IT coming down the line, but then there's also the continued challenges, and for us the biggest one is cost behind. Labor and employee health insurance, it's our third largest cost, which just really seems silly
It's
to me.
rising. Yeah.
Yeah.
But it's interesting you mentioned that ambient listening, because we've had to incorporate that into some of our internal audit and risk assessments, that background AI that can filter out sort of the banter from the actual medical conversation in the exam and document that in the record. And us trying to go back and audit, did the conversation translate to the right code and the right diagnosis? That's been interesting for us to kind of pick that up from an internal audit standpoint. Dr. Prather, how about you? The use of technology at your shop, where are you doing it well? The costs, what are the challenges for you?
Yeah, and I'm sensitive to time, and Dr. Yance did such a good job. I'll try to be somewhat brief, but yeah, I mean, we're even at our scale, we have about a dozen people from the leadership to the technician side, kind of help desk folks, to trainers on down the line that are on the IT side. And of course, that means we have a lot of outsourced support relative to data centers and all integration and interfaces and all this different stuff. And it's a huge part of the budget. It just is. And finding that kind of talent and at scale continues to be a challenge. But I don't, in what Dr. Yance said, it's such a blessing and a curse. I mean, for background, coming from an Epic shop, coming to a next gen shop, which is what we are, I had just I was scared to death about what we were going to find and relative to data, because the end user interface is one thing, right? I assume there's a lot of medical group leaders on here, and how much, your physicians and clinicians complain about how the EMR works for them and the clicks and working their inbox. And, that's all part of it. But of course, from my end, coming from an Epic side, used to a lot of pop health type data as we're thinking about value-based, a lot of business intelligence type data as we're trying to make decisions. And frankly, NextGen did better than I thought it would. The other thing that I will say is Dr. Yance exactly right. From a technology standpoint, the most interesting thing, we've ramped up ambient as well. Now, let me say this, and I hope I'm not breaking any contracts, but just keep it amongst us. Amongst all my the providers I mentioned, those ambient licenses, we think they're worth it. Clearly, there's no bigger burnout than making physicians and providers clerks, but our licenses are $5,000 a year, ballpark. I mean, so it's not inconsequential, but it's definitely a game changer. I've played with it some. It is amazing. Dr. Yance, the note that can be created from AI, that, what it pulls out, and the fact it does pull out the clinically relevant data from normal conversation is pretty dramatic. But again, there's an expense with that. And if people aren't seeing more patients, then it has implications. And we're trying to encourage people, to say, hey, let's put an extra patient or two on your schedule a day relative to this. So, that's what I would say. The care coordination with NextGen is versus an Epic, and there's a whole conversation we could have about continuity of care and how in a workflow we're trying to follow the patient across the journey. And we're working on we have some interfaces, and of course we can access care everywhere with Epic. But when you have a one-off system, which a lot of us do, because Judy Faulkner's not necessarily returning calls to community health centers or rural health clinics for implementation, nor could we afford it if she did, probably. It has implications around the care continuum. And so we have people on the care team who are spending a hell of a lot more time tracking down reports because we don't have an integrated health system. So there's trade-offs.
Got about 6 minutes left. Jeff, I want to hop back over to you briefly if I can. And, as a firm, we're always touting really our value prop to a client is helping clients protect or enhance their margin or stay out of trouble. That's really why we exist in the grand scheme of things. So, Jeff, what's one or two sort of words of wisdom or sort of key drivers you would suggest FQHC's rural health clinics should keep an eye on from a revenue standpoint?
Well, for both FQHCs and RHCs, I would strongly emphasize understanding your governmental reimbursement and your PPS rates, making sure and conveying that information to your staff on how PPS rates work. PPS rate is essentially a predetermined cost per visit amount that is based on your base year cost report, and it's updated by the Medicare Economic Index Factor each year, unless there's a change of scope of services, such as maybe an RHC added a psychiatrist, then another cost report would be due to include those services. Another suggestion I would have would make sure you're maximizing your 340B savings. Make sure you're capturing at a rate of all drugs, but particularly specialty drugs, is a key to reaping the program benefits. And lastly, value-based care. I read recently in the Wall Street Journal that there's a large rehab system, in national rehab system that treats drug and alcohol patients. And recently they experienced a large cut in their reimbursement from insurance companies because some of the patients they were treating were showing up in the ER on overdose cases. So I think the value-based care is here, and you're going to see that a lot more in services. So not necessarily churning out volumes of patients, but I think insurance companies are continually going to be looking at the quality of care and keeping folks out of the health system.
In our final minute or two here, let's get back to that underserved word, but in regards to your patient population. We talked about the staffing, but your patients in these areas, how do you engage with them? How do you keep them active in their care? How do you keep them to show up to their appointments, transportation barriers, all of that? Talk to us, Dr. Prather, about how are you engaging patients and keeping them actively involved?
Well, two things. One is and I should have mentioned the technology. We've invested in a patient portal through NextGen through a second vendor called IntelliChart. And it's not my chart, if I'm being honest, but it's pretty darn good. But even with that, let me say it's a nice engagement tool, but we've pushed it, and we still only have about 40% of our patients engaged. And so I think digital engagement is a lot of the key in the future, but you're still only going to get so much. Some of that's limitation of rural areas. Some of that's just maybe older folks not engaging. And so the secret to, we've had some success, but I'm not going to say I have any secrets to it besides throwing bodies at it. We have 10% of my workforce is what we call a care team, where it's either RNs for high risk care management, LPNs and MAs for some closing gaps kind of things. But those folks are touching base with patients constantly, trying to help get them situated for their appointments. I mean, people have navigator terms. We use care managers, different things. And so in a rural area, it's hard. And, there's no, even if you wanted to pay for Uber, there's no Uber. I don't think there is in Hazard either. I know there's not in Hillsborough, Ohio, Anthony. So, working with local agencies, we have a whole database around local agencies that will partner with us that those folks manage, and they play almost a social worker role. So it's really, we do okay at it, but in a rural area, there's just some services that aren't out there. And because of technology challenges and cultural challenges, if you don't have people dedicated to it, which again, where does that come from we chase a lot of grants for that as a result. I mean, a lot of times it's just a people and an outreach solution. So I only left you a minute, Anthony. I'm sorry.
Oh, no, similar challenges the same thing. We for transportation, link up with a local group. It's interesting with like Next Gen. We'd tried Next Gen, and all my providers said they were quitting because on the provider side, which I think they
You're not making me feel any better as we're closing this.
Yeah, no. I think that it sounds like they made some upgrades. But one of the things that I've incorporated and I've really been insistent with my providers is flexibility. So at the end of the day, we have folks who just cannot make their appointments when they need to, and then they'll have an aunt or an uncle or a cousin that's coming into town and they can drop into clinic that day. So we just have open schedule slots for those folks throughout the day, try to meet them where they're at. But Dr. Prather is absolutely right. I mean, it's just the challenges are tremendous.
Well, we're up against the clock. This has been fascinating and awesome and really educating, I think, certainly for me. But to hear from three experts navigating three different organizations and challenges, the work you're doing is tremendous and valuable. I'm sure frustrating at times, but certainly very important. So Jeff, Jody, Anthony, thank you all for joining us. We appreciate it. Thanks for the hour you spent with us. Much appreciated to the participants. Thank you all for joining. As I mentioned earlier, we'll have any follow-ups posted and we'll circulate the recording when it's ready. Thank you all very much.
Appreciate it.
Have a great
Happy
day.
to be of help and follow up if we can be, so just let me know. Thanks for the time.
Absolutely. Good to see you all. Thanks so much.